Time now for this week's Health Matters. I've got PA Lynn Szabo here in the studio. We kind of stumbled across a topic during last week's Health Matters, and I think we're actually picking that up today, right?
Yeah. You asked me I think what you asked me was when should universal health care be expected?
What I was asking was a kind of the free across-the-board availability of a lot of these different COVID, from the vaccines and things like
signaling anything?
Huh?
Was it signaling
Right.
anything?
Was it the leading edge of something, maybe a sea change in our attitude? And so, yeah. So what'd you find out?
I don't think so.
You don't think so?
No, but exciting stuff is happening.
Well, thanks for tune in next week for
there you go.
For a longer edition of Health Matters.
But there's it is, I guess, getting people to think about it. And some kind of exciting little movements are happening, but they're, in my opinion, kind of tiny.
Yeah.
But you're really starting at the question, is healthcare a right or a privilege? So, I think it's a right.
Is that what I'm asking?
Yeah, I think so. I think it's the start of any conversation about universal health care.
I think you're right.
Is it a right or a privilege? So I think it's a right. So I'm going to establish with that. Every developed country on the planet,
Not everyone,
except for the United States, thinks that health care should be universal, and they're actually kind of shocked when they find out here that it isn't. And the American system that we have is actually, we have like halfway attempts and 50, representing each of the 50 states and then whatever Puerto Rico is.
Right.
So
I wonder, okay, that's next week's topic. What's healthcare like in Puerto Rico? I'm thinking of moving.
Well, they have paper towels.
They have paper towels and black beans.
Right. So let's see. The government, I think, has caught up with the private healthcare business, and I think that's going to be the whole interface between right and privilege is defined also by capitalism or governmental service. And
sure. What do you mean by the verbal phrase "caught up with"?
I think that they're entwined together, and that I think the first thing that has to happen is that has to be undone. So, and it's got to be undone on a lot of levels. So pharmaceutical levels, actual primary care levels, specialty levels, tertiary care levels, which is like teaching hospitals. And what probably the average person isn't super aware of, but the technology levels. So the move to electronic health records was actually created a new profession, in my opinion, and was kind of advertised that there would be great benefits to the patient, and actually has made things worse. But it's made it better for the people.
Now you're glossing over a bunch of things that perhaps
totally.
the casual listener might not. Okay, so wow.
Right.
Wow, unraveling government being intertwined with the healthcare industry. Geez, I mean, you were talking about all the different medical fields and ways, and even employers, in just the public space that needs to be changed. I mean, there's so many, just like it's marbled through our. So my question at the end, and I want to remember to come back to this question, is that how do we do this? How do we unravel these things without burning the whole thing down?
Which has its own attractions.
That's
actually.
true. Yeah, I know, but not for
I think do you want to talk about that more at the end, or talk about what other countries have?
No, let's go through. Let's set up a content. Let's set the table. Let's talk about what other countries have.
Okay. So I know personally, because I lived in Denmark for a period of time and had to access healthcare there, is that it's universal. And I remember after my appointment, which was for a minor thing, I had like 7 doctors in the room because they all wanted to speak medical English. So I was kind of like the homework assignment of the day, I think.
Wow.
And then I said, well, where do I, okay, I'm going to get, wander down the hallway. Where do I go to pay the bill? And they were shocked that was even a question.
Oh my God.
And I got about a 10-minute lecture on why healthcare is a human right. So I do know in Scandinavia that the bill is not really presented to you at the time of care. You could argue that it's presented when your tax bill arrives.
Sure.
because it's definitely covered by taxes.
Mm-hmm.
But they also appreciate that. In the United States, there would, I think, be a knee-jerk reaction to hating that. But in the Scandinavian countries, they see that as kind of, they get more benefit from their taxes than they lose in losing the money.
Yeah, because they see it for what it is. It's a collectivization of resources and then a redisbursement. It's like, that's how it's supposed to work.
Yeah. So Sweden has universal health care funded by employees.
Employers or employees?
Yeah, I think probably both, because everybody pays taxes.
Mm-hmm.
But there's still associated fees for hospitals, primary care specialists, and prescriptions.
Mm-hmm.
But Norway has universal health care, also tax funded, so not really in the employment industry at all. But you got required copays, and then Canada, of course, publicly funded health care, but lots of stuff is not covered, and there's probably a little bit of a line to get to certain things. But how is that different from here? I mean,
right?
If you got to get your knee replaced, it's probably about a 4 or 5 month wait here.
I mean,
in Del Norte.
Forget the big ticket items like that. Even for somebody, for me, I mean, poor and not, I hadn't for years had like a primary care physician or anything like that. And so, so there was a delays just because I'm poor and I'm having to go through clinics and things like that anyways. Even in capitalism in America, you have delays and you have things. It's like, so I'll stand in line if I don't have to pay. But now I get to stand in line and go through and make a lot of calls and hopefully get an appointment and get in. And in Del Norte County, where there's availability issues.
Right.
And then at the end of it, I get to pay for it. That makes no sense.
Yeah. So the downside, lack of supply to meet the need. That's going to happen. That happens in almost every country that has universal health care.
Mm-hmm. Is it because just countries, I don't know, is it because countries lack the will to sort of make that supply more robust, or they're sort of afraid of doing that? Is it a funding issue? Do you know what the underlying factors are?
I think the need is always underestimated. That's what I think the underlying factor is.
Mm-hmm.
And then in a lot of these countries, they don't have ancillary healthcare providers like PAs or NPs.
Mm-hmm.
They aren't really a thing. Although in Great Britain, British Isles, they've got maybe 20 PAs. I think they're starting also in Canada. They do have some nurse practitioners. So what I'm saying is that they're sinking all the resources into people who are overburdened and kind of underappreciated.
Mm-hmm.
The National Health Service in Britain right now has terrible morale. And what that means is the patient's experience is that you're only going to be with your provider for 8 to 10 minutes.
Mm-hmm.
That's like for like chronic healthcare kind of stuff. That's, now you're laughing. Maybe, you're coughing. Okay.
Quick, get some universal health care.
What's it like if you had a primary care appointment at the clinic? So I'm not really on that side of it. I mean,
how long do you spend with somebody like that?
How long do you get, and is that enough?
Yeah. Again, once you're in the room, it's however long your own personal advocacy. If you're there and you're asking questions, I think you can keep a physician in the room longer. But if you're just there going, this hurts, whatever, and they look at 15 minutes tops.
I think some people would really like a 45-minute appointment.
Sure.
And they do exist for procedures, but not just for chatting.
Right.
But I think some people like to chat.
So do you think that in these nations that have better healthcare systems and are more geared toward doctors, I guess traditional doctors and nurses who are overburdened, two things. I guess first is I imagine your answer would be yes to the question, should there be more PAs, more nurse practitioners, more people in that sort of like tertiary or that mid-level kind of, immediate care, triage, whatever, and you can like back the doctors out the door a little bit?
And they should use them more appropriate. Yes, there should be increasing numbers, but also used more appropriately. In this community, oftentimes PAs and NPs are used as physicians.
Right.
And administratively, they're considered physicians. But when you're trained as a PA, you're told that, almost like every second that you're not a doctor, don't overreach. your job is to alert maybe a higher level of care. Don't try and wing it by yourself.
Sure.
And but that's not the reality when you're in the exam room.
Or when you're in a community like this too, where you don't have a lot
Right.
of doctors around.
Right.
Yeah.
Yeah. So, I agree there should be more, but there should also be the expectation that a physician is different than a PA that's different from an NP. And that they have different roles. And you should be able to walk in a room and realize that maybe this issue is a doctor issue, and to be able to get some actual doctor help with it.
Right.
But that did happen for a while early in my career. And then up here, it's kind of just because of the nature of the underserved, it's kind of gotten away from that. I mean, PAs are pretty competent, and nurse practitioners too, and we can handle a lot. But part of the trick of being a PA is you have to know what you don't know, which is kind of tricky.
That's tricky for most people.
Right.
But right, exactly. But
Right.
but do you find? I mean, so just in your own experience, and this is a tricky question to ask a PA, but. Most people, when they walk in with whatever conditions, maladies into an exam room, what percentage of the time can their issues be adequately addressed by, say, a PA or a nurse practitioner or somebody not?
They have data on that, 75 to 80% of the time.
Right.
Yeah.
Right. Yeah.
Right.
Well, and when you go to Open Door, when I go to Open Door here, at least here in Del Norte County, I'm not sure I'm ever seeing a doctor, and I know a couple of times I've been, with a PA, I'm not even conscious of who's in the room with me. They just come in and start asking questions in an official capacity.
I always identify myself. Yeah, and so the hint is if you're communicating with this person by their first name, they're likely a nurse practitioner or PA.
Oh wow, okay.
If you're communicating. People are referring to Dr. So-and-so.
Well, yeah, that would be a giveaway. There's a tell.
That's kind of a hint.
Go ahead.
We're supposed to have white coats on that have our names embroidered,
that doesn't always, yeah.
Yeah, the whole white coat thing is another whole
We have a white coat right
We do.
there.
I say it showed up here
See,
somehow.
they can be anywhere.
So I have a question. And so I'm old enough to remember kind of being on the tail end of when doctors were still doing house calls. And once again, I mean, it's a different environment. I grew up in a big city, but there were actually like doctor's offices. They were just like doctor's offices, and you would make an appointment and you would go to the doctor, and it was just the doctor.
And it was just in some building somewhere.
And just some random kind of
there used
office
to be one
building.
out on Point St. George, I think.
Right.
Actually.
And so I mean, I was a lot younger then and wasn't in need of, so many medical services, but that sure seemed to be a heck of a lot better scheme for getting treatment for the most part.
Sure.
For the patient it is. I would argue for the doctor it's not.
No, but actually capitalism changed that, okay? So capitalism made it financially impossible to have the single, like Dr. Casper. Insurance companies, there's no negotiating power in just being an individual. And so when you start to have clinics where there's more, I guess, a louder voice because there's a group of people advocating for the same thing. And then electronic medical records bankrupted. Like that Crescent City Internal Medicine is still functional in this community. It's like a great tribute to Dr. Blundell.
Right.
Because electronic medical records opened up an opportunity for IT to be involved in medicine, and it was hugely expensive. And a lot, and because it was legally required, a lot of offices paid a lot of money for it, and then couldn't keep the bottom line, couldn't keep the doors open because financially they couldn't support it.
Wow.
So, but then there's a whole new career of IT guys in medicine. Mm-hmm. All right. So this is why I think getting back to universal health care, that there are costs that are kind of hidden to the patient consumer that I think are going to make it really difficult to go back. Like
to go back, how do you mean? To go back to what?
Either to go back to the single doctor in the doctor's office, doing home visits and things like that. But also it's going to make it hard to have universal health care because how many different electronic medical record systems are there?
Would we be faced then to address the scam that was the electronic medical records movement? And I mean,
Well, I don't think they think it's a scam. I think they honestly think that they're doing well. But
really, who?
The IT.
Well, sure, the IT guys, but
Right.
I remember anyway. I'd love to do another show about that. I think we've talked about that in the past.
Right.
But that
So
whole
productivity down 30%. Okay.
Wow.
No, it was sold for communication between systems. So, like hypothetically, people are super amazed that I can't like tap into somebody's records,
Right.
like in Medford,
Right.
Like Asante, for example, or I can't tap into St. Joe's Providence, and that there's no communication there. So. The first thing they need to do for universal health care, in my opinion, is get a universal electronic medical records.
Yeah. Yeah.
Okay.
Right.
So, and then the other thing that would happen, I think, is that probably the individual offices at the primary care level would consolidate. So a lot of the 95-210 clinics, so we've got 3 of them, maybe 4 of them. And so those are federally funded, federally supported clinics. I think we have 4 in Del Norte that I
Wow.
can think of. So UHS, Del Norte Community Health Center, Sutter Coast Community Clinic, and the new Stellant Clinic coming
That's
in.
That's interesting. And when you say UIHS, there are a number of different locations just in there too. I just wanted to point that out.
Right.
It's not one clinic like that.
Right. With Humboldt, Open Doors, number of different locations. I think they would try and consolidate that in kind of a Kaiser model. Mm-hmm.
So administratively, they would pool things.
Right.
Yeah.
And then you'd have to think about who's paying the bills. And we have various insurance companies. They're not going to go quietly into that dark night.
Yeah.
I mean, they're going to fight that. Mm-hmm. So there's going to be a lot of restructuring from the ground up. And maybe we do have to burn it all down to build it all up. So this is way more complex than you would think.
Well,
Yeah, exactly.
And I have a couple of questions. But so the first one is, earlier, I think when we started this off, you said something about government being entwined with medicine.
Right.
And I
With
think
insurance.
Well, with business, the medical industry,
The capitalistic side.
and I realize that maybe this is just semantics, right? But I don't think it's that. I think it's the medical industry being entwined in government, because I think that the medical industry has increasingly injected itself and wrapped itself around all the aspects of government and all the decision making and all of that, which has taken us farther and farther away from you could just walk into the doctor's office with like 10 bucks.
And you're right, that is semantics.
Yeah.
But I see exactly what you're saying. If it were the other direction, then we'd probably be closer to universal health care if it was proactive government action.
Right. Yeah, because I think that's an important thing to say, though, right? Because it may be semantics, but it's an important thing for people to understand.
Yeah, I see that as kind of a feedback loop.
Yeah.
Okay, so they're the yin and the yang. They both make the whole. Yeah.
I don't know. I think the underlying point is that what you're saying is the government, when we talk about government enacting these things, all of that, I think we're assuming government has a lot more power and heft than it really does, because industry and business has also tried to undermine the role and influence of government at the same time that it's trying to control it.
Well, and I may not say this the way I really mean it, but with almost any kind of like guild activity, right? A lot of the guild activity is designed to make sure other people and other entities exclusionary, or like you have the complexity of the logging industry in California, which for years supported the gigantic, clear cutting companies, but strangled the smaller, family oriented logging.
Sure.
businesses.
Is this analogous? This is getting so into the weeds. I'm sorry. We'll come back. But is this analogous to all the gas stations in California 25 years ago having to replace their tanks? Government comes in and says, you have to replace these tanks. The only ones with the wherewithal to survive that were the corporate ones and not the independent mom and pop gas stations, which is why you never see those anymore.
And very often you find out when you dig a couple of levels below the surface
That
that
even
it was those
yeah.
industries that were actually
Right.
pushing for that.
Yeah,
You know,
yeah, exactly.
Right. Like, and like who's pushing for all of these things that
Right.
make it harder and harder, except for the big players,
Yeah.
to be able to actually comply with these new regulations, which in effect limits their competition.
exactly.
Yeah.
And that's the feedback loop, exactly
Right.
as you said. Yeah.
And I think if you're going to establish a universal healthcare thing, is it like one for all and all for one? Like,
Well, the single
does
payer model?
everybody get the same work under the same model, or is there like a side thing that somebody with the, with the resources could kind of buy a little side
or even
insurance and maybe get their knee replaced, not at the universal healthcare clinic, but at Dr.
At the government shop.
Super knee guy. Yeah.
Yeah.
So
At the 5-year plan Politburo.
right.
Is that a government knee or is that a
Yes.
Yeah, I imagine it would be I mean the only way it seems like you could even sell anything like this. And yeah, this is the first time that I've gotten into a conversation about this and realized just how incredibly impossible it would be in the United States without burning everything down. But you'd have to add like, okay, here's your like it's like universal income, right? Here's your universal health care. Here's what you're entitled to. Oh, you want something fancier? Oh, you want it sooner? Things like that.
You want cuts in line? Yeah.
Exactly. It's Disneyland.
Yeah.
Yeah.
Yeah, absolutely. And that also keeps capitalism in it. And I mean, do we want capitalism in it or out of it? So,
I don't think we would be able to, as a society, as an ignorant society, face the prospect of anything without capitalism being left in it in some regard.
right, in some regard. But, things are happening in California. So proposal for universal health care kind of has a name in California, CalCare. I actually saw a logo for it.
And this is how
kind of cool.
What do you know about CalCare? I know nothing other than, in fact, just now I learned the name from you, but I knew that there was something there. But what are do you know have any details?
So everybody is kind of like cautiously sticking their toe in the pool. So the new proposal for the California budget sets aside about 20% of the budget for preparation and starting for universal health care. That's kind of amazing. I think if that's a proposal. So if it gets through and the system and it's still intact, that would be amazing. But it seems like we're kind of open the door crack even to talk about it, and that they're starting to talk about it on the money level. I think is kind of refreshing. So the goal for CalCare is to make it universal and free. Okay. It would solve the problem in California's population at 39.78 million. 7% or 2.7 million people have no coverage. So they want it to look like, at least what I was reading, look like an expansion of Medi-Cal. But there's also problems, with how you define who's a citizen in California. So, the migrante population, how are we going to, they're really here, they really have health problems. Are we going to take care of them or ignore them? But here's the thing that blew my mind when I was researching this. On January 11th, 2022, so not that long ago, the California Medical Association supported the setting aside of the money for an attempt to universal health care.
Any idea about that? Why? That would seem that's counterintuitive to me.
Well, I think maybe it's possible they see some inevitability in it, and that they want to be at the game early.
Okay.
So they want to in terms of the foundational work to start the ball rolling. They want to be involved. They want to be a player. The other thing is, I think they're kind of happy to see that it's being financially thought about. Mm-hmm. So, but
Instead
the nurses
of just mandated, we're actually trying to pay for it first.
Yeah, the California Nurses Association supported universal health care for a long time, and they have looked at it from a much more humanitarian point of view. But the CMA, the statement that I read was really focusing on the financial, which is so far the only thing that's really happened except for the logo. that I could figure. So everybody's kind of like starting to position themselves and to be off and running.
Wow. That's
So I
interesting.
think it might be kind of, sort of, at least starting.
Huh.
Yeah, this might be a conception. Who knows?
You may have addressed some of this earlier, but it seems like actually COVID is a real opportunity to move
Sure.
these things forward.
Totally.
Because on the one hand, we're getting all of these vaccinations and other medications related to COVID at no cost to the individual.
Hypothetically.
Well, hypothetically, I mean, I know that if I go, so at least to the best of my knowledge, if I go and get a COVID vaccine, nobody's charging me for it.
No.
I mean, obviously it's getting paid for. It's just not coming out of my pocket.
Right.
And then the other thing, and I don't know if this is true or not, at one point, were people who were actually hospitalized or getting other kinds of, more than just vaccines for treatment as a result of COVID, were those bills being excused as well?
I think initially those bills were being paid by the government. So they excused only on the individual level. But I don't know how much longer the community, the entire United States is going to have patients with unvaccinated people creating a super big health problem for themselves.
I guess where I was going with it was more along the lines, well, if these health care needs can be covered by the government,
Why can't
these other ones?
That's why I asked this question last week about that. Since all this is being paid for and distributed, and here we are, we're able to do this.
Right.
Why don't we do this
Why
more?
can't we do this for HIV or Hep C or diabetes or, insulin? And
Yeah.
that's a super good question.
Huh.
So I think what happened was as far as for respect for COVID, they didn't think that it was going to go on as long as it did. Mm-hmm. I think the enormity of the problem took them by surprise. I think when they thought it was going to be smaller, then that was a good reaction. It was a humane reaction. And now that it's huge, I think they might be reassessing some of that.
Wow.
So capitalism again in medical decisions. So, but who knows?
I don't know.
I would like it. I can talk personally for a minute. So I've always had healthcare and have been on Medi-Cal in my, kind of certain parts of my young adulthood, and never really thought about it until I got COVID laid off. And so I had my healthcare taken away kind of in about a month. It disappeared.
Wow.
And then so I was doing, kind of fill-in medicine for people here and there, but that's not a benefited position.
Yeah, you're like a freelancer.
And so I've kind of gone through most of the pandemic with no health care until recently.
Wow.
And I've been buying my health care on the exchange, California Exchange. But I was getting policies that were essentially major medical policies, and they were hugely expensive. And, I had to kind of let covering healthcare for my kids go. And so they all went to Medi-Cal. And then the other thing is I can't really use it because not only is it major medical, so huge deductibles and things like that. But if I need some orthopedic stuff, that means that I would be off my feet mandatorily for a couple of months. Then I wouldn't be working. Then how do I pay for the health insurance every month? So even as a healthcare provider, I can't really access healthcare.
Wow. Do you get like an employee discount? You don't.
Some places I work, they do that.
Really?
Some
So,
places have locked that down. 'Cause
Wow.
you used to be able to wander into the lab and say, "Hey, can you check my blood sugar?" I mean, or we got this new X-ray machine. You want to test it out on my ankle? And so I would be able. You can kind of curbside people into healthcare, but that's if the answer is you need to have your ankle, or your knee replaced, then that's that kind of stops there. It's not like
Yeah.
it's extendable.
Right.
But I find it really ironic that the health care that I give to people is way better than I can receive ever.
That is-
Until maybe I'm on Medicare, which is about a year.
That is a common capitalist scenario, right?
That
there.
is not an uncommon thing to happen. There are a lot of healthcare providers that I've known in the 2 counties who worked probably longer than they should have because they were working for insurance.
Wow.
Yeah.
So it seems to me that the only way it can get burnt to the ground is if the healthcare providers light the match.
Is it big? Is it still just a healthcare fire we're setting, or does it need to be bigger?
Well, I guess what I'm saying is, I haven't fully thought this out, so it may be stupid, but
It's Sunday morning.
Yeah,
is what we're doing here.
because the people who need the health care, they have no power to burn it down. The only people who have the power to burn it down is the people who can actually stop it in its tracks.
Right. Good point.
And the executives in the healthcare industry aren't going to do that. The bean counters aren't going to do that. The IT people aren't going to do that. The only people who can do that are the people who actually can deliver the services.
Yeah.
Interesting.
Well, I'll tell you, healthcare providers are, kind of close to like that. They're close to burning it down.
Unknown caller.
Ooh, that's scary.
There you go. Talk
That's not
about
me.
burning it down.
I know.
Start getting unknown callers.
Uh-oh, they've heard what you're saying.
But I think doctors. I'm
Nice
sorry.
ringer, though.
I know.
wow.
It's way too loud, though.
That's all right.
I'm really sorry.
We should wrap up anyway. We're 30 minutes.
Okay. Yes, I think that electronic medical records and COVID and insurance companies have really, tested the patience of healthcare providers, and I think a lot of healthcare providers are super over it. And I think they might be looking for matches.
So is that where we leave it? Is the call to action here at the end of this week's Health Matters that it's up to the healthcare providers to start kicking things over?
I think this is a big enough problem that it's up to everybody.
Yeah, but who, like what Mike was saying though, who has the power to really affect any of that change? Government isn't going to do it. Anybody on the capitalism side and making money from the status quo isn't going to do it. The people who need it don't have the political power to do it or the economic power to do it.
Yeah.
So who's left? It's the people it's you.
Yeah.
You want some matches?
Yeah, I'm totally in. But I would also observe never piss off a nurse, and they're pretty pissed off right now. So, then I'm wondering, it would be kind of interesting if the nurses led the charge.
Wow. Okay. All right.
We're going to back you, Che.
We will. We will. That's nurse Che. to
Nurse,
you.
oh, I'm sorry.
I'm not a nurse,
PHA.
but
PHA.
I am conditioned to do what I'm told by nurses, so that's good. Anyway.
All right. Health Matters. It's all getting burned to the ground, and we'll start again and do it better this time, I guess. Or we'll come back next week and there'll be something to talk about COVID. Any idea what you'd like to talk about next week?
You know what? I think maybe I'd like to talk about what you do if you get the diagnosis, because you get told to stay home, and if you're not feeling well and mildly terrified, and all of a sudden there's nobody to talk to.
Oh, wow,
No
yeah.
medical person to talk to, and you read like Paxlovid could be a thing, but there is none up here, and like what should you do to take care of yourself, because you're really going to have to be independent on this one.
That's a great idea. That's a great idea for okay. All right. I look forward to that. That's
Okay.
Next week's Health Matters.
Okay.
All right. All right. Anything else?
Nope.
Okay. All right. Thank you very much, Lynn Szabo,
Thanks.
PA.
Yep.
Arsonist.
I did not.
Revolutionary.
Revolutionary.
Oh.